examination of the motor system, which includes inspection, palpation, as well as the assessment of individual muscle groups power. So regarding the inspection, we have to inspect the patient and look for any atrophy or hypertrophy. Now you can see this patient. So he has a good shoulder contour. There is no wasting in the shoulder contour is there, and the biceps and the triceps contour is well maintained. You can show the forearm. So forearm bulk is also well preserved, and there is a thenar eminence and hypothenar eminence are well seen. Can show, and the tendons are not visible here. So that shows that his intrinsic muscles are good, well preserved. And regarding the thigh, can you relax? There is no wasting of the quadriceps. There is no wasting. You can step a little bit. Yes, thank you. You can see the tibial bone is not well seen, so the contour is maintained. The shin of the tibia, you can see the anterior bone is not common, which shows that there is no wasting in the anterolateral compartment. And regarding the posterior aspect also, the calf muscles are well preserved. There is no atrophy, or this is the palpation. So palpation you do in case of if there is any myositis, where there can be muscle tenderness on palpation of a particular muscle. Regarding the tone examination, the first instruction which you should give to the patient is the patient should relax well, because tone is the degree of the resistance which the muscle offers to the basal movement. So that is called as tone. So for that, the patient should relax. So I will ask him to relax a little bit, where I will only do the basal movements and assess the resistance offered by the muscles. So to begin with, you can examine individual upper limb and lower limb separately. First, I will show you the upper limb tone examination, where you have to be gentle and also you have to be ask the patient to relax. So you have to move passively. So I will show you. So now relax. Don't do any movement, which I will do. So now regarding the supination position, first I will see. You can see the resistance offered. It is not too low, it is not too tight. It's normal. And regarding this joint, there is a passive movement. It's not too tight, too loose. Upper limb again, like this. It's not too tight, too loose. It's a normal tone, examining normal tone. And regarding the tone examination, there is a difference between spasticity and rigidity. Two types of tone abnormalities which you can take. Both are called as hypertonia. And regarding the spasticity, you will have a resistance only in one direction, either in the against or antagonist. But in rigidity, you will have resistance to both the directions, either reflection or extension. You will have a resistance that is called rigidity. So rigidity involves both the groups, whereas the spasticity involves only the one group, namely the antagonist. Regarding the lower limb examination, you can just ask the patient to relax, and you can lift this knee joint, and the limb will slide passively. Ask him to be relaxed. If he relax, just do like this. That's a passive. Ask him to relax. Don't move. So you can do like this. Press the sliding. If there is hypertropia, the sliding will be very slow. So this is how you examine the lower limb. Another technique to examine the lower limb is just log roll the limb to look for any spasticity. See, log rolling. I am not able to feel any tightness. It's easy to log roll it. So you can log roll like this. This is one method of examining the lower limb. Now I am going to examine the strength assessment of various groups of muscles. Regarding the power examination, you have to grade it according to the MRC grading or the Medical Research Council grading, where 0 is no movement, 1 is a flicker of movement, 2 is the movement with gravity elimination, 3 is labeled as movement against gravity, 4 is resistance offered by the patient to the examiner's resistance, and 5 is normal power. So now I am going to examine power examination of the upper limb. So to begin with, I will start with the shoulder flexion and extension. Regarding the flexion, you ask the patient to flex the shoulder. So you can offer a resistance here. Can you flex the shoulder? And you can feel the anterior axillary fold. The pectoralis major is contracting. And regarding the extension is contributed by both the posterior fiber of deltoid as well as the latissimus dorsi. And regarding the extension, can be extended backwards. And you can palpate the muscle tightness here. palpate the muscle here, and I can feel the resistance offered by examining the latissimus dorsi. Another way of examining latissimus dorsi is you catch hold of the latissimus dorsi, which is in the posterior axial foot, and ask him to cough. When you cough, you can feel the latissimus dorsi contraction. This is one way of assessing latissimus dorsi. Next will be shoulder abduction. Initial 15 degree will be the supraspinatus, 15 to 90 will be the front, and more than 90 will be the trapezium. So for that, it's clear. So now I'm going to examine the shoulder abduction, where he has to initial 15 degree will be the supraspinatus. This will be the testing the supraspinatus, and from here the 90 degree we have to fix it, and I will try to press down. He should not allow me. I will try to press down. He should not allow me. So this deltoid powers, you can examine the deltoid. It's contracting well. This deltoid power is good. And regarding the adduction, as I said, we are testing the latissimus dorsi. We will be testing the adduction. And regarding the pronation and supination, you can examine. You can try to pronate your hand. I can offer a resistance, so I can feel the resistance which he offers. And regarding the supination, can supinate, I can give resistance here. And regarding the pronation supination, you can mention either normal or weak. It is difficult to grade the supination and pronation power. And regarding the wrist, you can hear dorsiflexion. You can give an equal resistance like this, dorsiflexion. And regarding the palmar flexion, you can give an equal resistance like this. This is the palmar flexion and dorsiflexion. And regarding the individual muscles, what you can do is you can examine the extensors, the lumbricals. You can fold like this. You can extend the fingers like this to test for the lumbricals. And regarding the intrasal, can you expand? So you can give a power. So you can test the power, the resistance offered. You can test this power. And regarding the abductor pollicis brevis, actually you can lift this here. Can you pick? Regarding the abductor pollicis brevis, can you lift the finger? Yes, I can feel the abductor pollicis brevis. I am matching the muscle with my muscle. And testing the intrasal, can you match your finger with this finger? This will be more accurate. Coming to the lower limb. So for lower limb examination, it's ideal to make the patient lie down. So in lower limb, we are going to examine the hip muscles, the flexors, extensors, abductors, adductors, knee flexion extension, in toe flexion extension. In ankle, there's a dorsiflexion and the palmar flexion. And in subtalar joint, we are going to examine the inversion and inversion. So these are all the major muscles which are going to test. So I am going to examine the reflection. For that, instruct the patient to lift his leg upward without bending in. Can you lift up? Lift up, lift up, lift up. So I can feel the resistance offered by him. This is how you test for a hip flexion. Next will be knee flexion and knee extension, which has to be done. Any flexion. So now I will try to push in, and he is trying to extend. This is called knee extension. I will try to push it in. So this is how knee extension is tested. So I am trying to push it against him, and he tries to extend it. And since the quadriceps is powerful, it can overcome it easily. This is how knee extension is examined. And regarding the knee flexion, when you flex them, he tries to get it, and I try to pull him outward. This is how knee flexion is tested. And regarding the hip abduction and adduction, you can flex this both the legs. Can you spread your legs? Spread it. So now you can offer the resistance to the hip. And can you bring in the two legs together? This is how adduction is tested. Next, hip extension. So for that purpose, hip extension, he has to roll backwards. He has to be in the prone position and properly instruct that you should lift your leg and should not rotate your pelvis. This is the extension which I have given. You have to flex this, flex this, and he has to lift like this without rotating his pelvis. This is how the extension is tested. Now he is going to lift against the resistance. Can you lift? Can you lift? Yes, I can feel the resistance. Similarly, I will show you. Just stabilize the pelvis so that he doesn't rotate and lose his effect. You can lift upwards, lift upwards. So I'm testing only the extension. And another method of testing knee flexion is you can fold the legs. So you can do it against you. So you can bend your legs, bend your legs, bend your legs. This is another way of testing knee flexion. Can we come back to supine question? And now I'm going to examine plantar flexion and dorsal flexion. I'm offering resistance here. Can you press down? Yes. This is plantar flexion testing against resistance. The accessories are the main responsible muscles for plantar flexion. They can easily overcome your body. Regarding the dorsal flexion, I can give a resistance here. So he's able to overcome. So it's a normal power. And regarding the inversion and eversion. So for inversion, it has to invert his legs, turn inwards against the resistance. So I'm giving resistance here. Can you turn inwards? So this is what? This is the inversion system. So you can easily invert. So regarding the eversion, you have to give resistance by turning outside. So I'm giving resistance here. Can you turn outside? This is eversion system. After testing the muscle power, we are going to test the superficial and deep reflexes. Superficial reflexes, we are going to test corneal reflex, abdominal reflex, and corneal reflex as I have already shown you in trigeminal. Now we are going to see abdominal reflex, how to do abdominal reflexes. So ask the patient to lie down and expose the abdomen. And expose the abdomen. You can expose till here. Till it is have to expose. Now you have to make the quadrants using a blunt object, either in the back of this knee handle or using a blunt key, which you can do that. So you have to draw quadrants, like you have to draw like this, like this, like this, like this, you can see, and look for any contraction. In pendulous abdomen and in patients who have multiple surgeries, you may not get the abdominal reflex. So you have to see the contraction of the abdominal muscle by stroking. You have to give a firm stimulus using a blunt object. Next, we are going to see the plantar reflex, which was described by Venkatraman 100 years ago. It is one of the vital signs in neurology, which indicates the human involvement. So for that, ask the patient to lie down. Should not catch hold of the muscles here. Should not catch hold of the body. Keep the legs straight. Just hold like this, and start with the firm stimulus using a blunt object like a key. You can start in the lateral border and go towards the medial one. So this is how you have to do. First, I will start from the lateral aspect of the sole. I start like this and do firm stroke stimulus. Where there is a response, is a plantar flexion of all toes. This is the normal response. And when you tell it's a Bbbs reflex is positive, there will be an extension of the great toe followed by fanning out of the toes. This will be the abnormal plantar reflex, or otherwise known as Bbbs positive. So normally the plantar reflex will be resulting in plantar flexion of all the toes. That is the normal response. I will demonstrate you in the other side also. Just use a firm stroke stimulus. Start at the lateral border of the toe. Don't catch hold of the muscles. Just keep for support. You can go like this. So you can get a plantar flexion of all the toes. Examination of the deep tendon reflexes. In upper limb, you have to examine the biceps, triceps, and supinator. In lower limb, you have to examine the knee jerk and ankle jerk. Biceps and the supinator root values are C5, C6. C7, C8 will be the triceps root value. In knee jerk, it will be a predominantly an L3. The ankle jerk will be an S1. Patient should be relaxed. The hammer which I use is a queen square hammer, which has a long handle and a soft rubber. It's flexible. So, regarding the striking of the hammer, you should not hold this hammer and strike on the tendon. Rather, let loose between your fingers to strike the tendon. So you should roll like this, not hold like this and hit on the tendon. So you should do it gently, and you should put the whole weight of the hammer should strike the tendon. So this is how it is usually done. So I will show you how to do it. First, regarding the bicep, you have to expose the bicep stretch of the biceps, and you have to ask the patient to partially flex and you keep it on the tendon and keep a finger like this, and you can strike on the tendon just to see the biceps contraction like this. And regarding the triceps, ask the patient to relax straight, keep like this, and you can strike on the tendon. You can feel the contraction. You can see the contraction and also the extension movement. And it should come like this. For supinator reflex, you have to hide the hammer on the radial styloid. The help of the finger, I am going to hit on the radial styloid. So there will be partial elbow flexion. This is the normal response of the supinator jerk. For the knee jerk, you should ask the patient to relax, and he should hang the lips down, and you can strike on the patellar tendon. You can palpate beforehand, ask the patient to relax, and we can speak like this so that we can get a knee extension response. Again, I am showing this. This is the knee extension response. Next, regarding the ankle jerk, you have to give a partial dorsiflexion before testing the ankle jerk. You have to partially dorsiflex, like you have to partially dorsiflex here. Don't completely dorsiflex here. It's a partial dorsiflexion, and you can strike on the Achilles tendon like this, where you can get it. So, are you able to see the plantar flexion? Now, I am going to examine the coordination and gait for this subject. Regarding the coordination, we have to use a finger nose finger test or a tap test, and in the lower limb we can use a Kielsen test. So regarding the finger nose finger test, I am going to ask the patient, can you touch the tip of your nose and can you extend your lip like this? Outwards. Yes. Can you do it once more? So he is able to reach his target accurately, and there is no particular coordination. Can you do it at the other end? Now I am going to make the test little difficult by asking him to touch my finger and again his nose. Can you touch your finger and my nose? The nose. I will show you like this. So I will keep moving this target so that you can do it accurately reach my finger. You can do it that the other. Can you try with the other? This is called finger nose test. Next will be the lower limb Kielsen test or the tapping test. For that, he has to lie down. Can you lie down? This is for testing the coordination of the lower limbs. When you have to take your heel and strike on the patella, and you have to slide it in a straight line. And again, you have to take it here and you have to slide it. So, can you do it? Slide in a straight line. So, he is able to do. He can slide in a straight line. Can you repeat with the other limb? Now he can do this. He is doing the, he is sliding on the straight line of the shin of the tibia. Thank you. Now regarding the rapid alternating movements, you can do a foot tap test, and also in the hands also you can do, you pat on the thighs. So I will show you how to do that. First, regarding the hands, just tap on your thighs alternatively like this, fast, as quick as possible. You can tap fast, as quick as possible. This is for checking the rapid alternating movement. You can do it with the other limb as quickly as possible. Yes. Now with the foot we can do, just tap your foot as rapidly as possible. Tap. Can you repeat with the other limb? Tap rapidly on the floor as fast as possible. Yes, thank you. This particular coordination is intact, and now we examine the gait of this patient. So now we are going to examine the extrapyramidal system, which includes the assessment of bradykinesia, rigidity, postural instability, and also the pathological reflexes. First will be the glabellar tap, where the patient will have a non-accommodative type of glabellar tap in a Parkinson's disease or an extrapyramidal system environment. And in a normal individual, they will be accommodative. So for that, you have to tap on the glabella, and you have to take your fingers not directly into the glabella in order to avoid the nasal reflex. So go around and come here, and you start tapping here. So he is not closing eyes every time because the glandular calf has become accommodative. This is a normal response. In extrapyramidal involvement, you will have a non-accommodative glandular calf where the patient will keep on blinking for each and every time. Next, you can examine for palmamental reflex. It is a primitive reflex. You can stroke the thumb with a blunt object, either with a nail or with a key, and you can look for a contraction of the mentalis muscle. So I am stroking the key with the thumb. There is no response. It is one of the primitive reflexes found in extrapyramidal system due to the release reflex from the frontal lobe. Next will be the assessment of bradykinesia, where you have to ask the patient to tap finger rapidly and also with a good amplitude. You can tap like this quickly, rapidly. So there is no decrement in amplitude or no decrease in the speed, which is the bradykinesia, which is characteristic of bradykinesia. Whereas in spasticity, the amplitude may not decrease, the amplitude will be constant. Whereas in bradykinesia, the amplitude will keep on decrementing like this. It will become further slow. This is the difference between bradykinesia and spasticity. Whereas in spasticity, the patient will do it very slowly, but the amplitude will be constant. There is a difference between bradykinesia and spasticity. Next will be the examination for a tremor. So regarding the tremor, you can ask the patient to rest like this, and you can look for any resting quality of tremor which you will get in various extrapyramidal systems, or you can also activate the tremor by giving some arithmetic calculations to him and distract him so that if there is any re-emergence of tremor. This is for examination of a tremor. Next will be the postural instability, where you have to give a postural challenge to the patient and they should balance it. For that, you have a push and pull test, which I am going to demonstrate to you now. So now, ask the patient to stand here and give instructions to them. I will give a gentle pull backwards and you should balance within 3 steps. This is the instruction which you have to give to the patient. So, and always be ready to catch hold of the patient so that he doesn't fall on you. And I am giving a gentle push and he has not come. Even if he comes back, he should balance within 3 steps. That is how. And postural instability is tested. And you can repeat this in the anterior direction, where you give a postural challenge, gentle tap on the backwards, and he is not coming. He is not coming forwards. This is how you do a postural stability challenge. Regarding the examination of rigidity, I have mentioned already in the tone. So you will feel the resistance in both the agonist as well as the antagonist. In case of rigidity, there are 2 types. One is lead pipe rigidity, another one is cogwheel rigidity. In lead pipe rigidity, you will experience the resistance throughout this movement and throughout this movement. This is called a lead pipe rigidity. Whereas the tremor, when the tremor superimposes on the rigidity, you will feel a breaking movements in between. When you try to flex like this, you will feel a cogwheel rigidity like this. Okay? You will be breaking like this. So this is called cogwheel rigidity, which you may get in extrapyramidal dysfunction. So coming to the final portion of the examination, you have to look for meningeal signs of irritation and also examine the cellular cranium. So for that, you ask the patient to lie down. There are 3 signs of meningeal irritation. One is the neck rigidity, another one is the rhodesian sign, another one is the neck sign. I will demonstrate you what it is. So regarding the neck stiffness, there is a difference between a meningeal neck stiffness as well as a neck stiffness due to extrapyramidal dysplasia, progressive supranuclear palsy. For example, if you have a neck stiffness, you have to be gently. Okay. You can try to flex here, flexion extension. I am able to flex freely. But the main difference in extrapyramidal disease is, in many cases, the side to side there won't be any stiffness, whereas in extrapyramidal, the side to side movement will cause stiffness. That is the main differentiating point between a sign of meningeal irritation and a stiff neck due to diseases like progressive supranuclear palsy. Next will be the rhodesian sign, where there will be, if you do a neck flexion, the knees will get flexed. That is called rhodesian sign. And there is a, when you try to, this is the Kennick sign. When you try to extend the knee, you will feel a resistance. The knees won't extend extensively. You will feel definitely a resistance when you try to attempt to extend the knee. This is how you demonstrate it. Here fixing. If we are going to examine spine and cranium, and we can inspect the skull for any gross abnormalities of the bone, any history of any bony defects of the neurosurgery in the past. You can ask. You can see the scars also if there is any. Then we have to examine the spine, where the cervical lordosis is normally present. There is a concavity in the dorsal spine. Again, a lumbar lordosis is present. There is no forward bending of spine. Now you can look for a lateral bending of spine. Run your fingers over the spine so that you can feel if there is any lateral bending. There is no lateral bending. There is no scoliosis in this patient. This concludes the basic neurological examination for psychiatric postgraduates. For the first years and second years, you can start reading bigger stuff neurological examination for a general neurological examination. For higher metal, you can use black and stuff. For last minute revision, you can go through McLeod or Hutchison's clinical methods quickly, which you would have read in your undergraduate days. Thank you.